Welcome everybody to the State of the States webinar, where healthcare legislation stands around the nation. We are going to talk today a little bit about specialty tiers legislation, which is a really hot topic. And then we are also going to discuss some other things and other bills that you might see pop up in your state, and then also go over some alternative advocacy strategies. So thank you, everybody, for being with us, and we look forward to a good webinar. With us today, we have Kelly Fitzgerald, who is the Associate Director of Donor and Government Relations at Patient Services, Inc. She's been at PSI for 10 years and is also the co-chair of the Virginia Specialty Tiers Coalition. So I will have her get us started with a brief presentation on specialty tier, an overview of the issue and where it stands around the country. Kelly?
Hi, everyone. Can you hear me okay?
Yes, we can.
Hi. Okay, great. Well, thank you so much, Katie, and thank you to HFA for having me today. I'm so happy to have the chance to speak to you guys about specialty tiers and sort of give you an overview of what the issue is, what the challenges are surrounding these types of medications for patients. There's a lot of access barriers. And it's something that obviously has been very important to Patient Services, Inc. and HFA as well, because it affects so many patients that we work with. PSI has about 27,000 patients on service today in all 50 states, and they're very varied, obviously, but the one thing that unites them is that the types of medications that they need to live productive and good lives are unfortunately sometimes out of reach. So what we do in our advocacy department and in conjunction with HFA and other organizations is try and work on things that will get our patients better access to those things. So again, just happy to be here today, and we will take questions at the end if you have any. So we'll go ahead and move on to the first slide. Okay, so what is the issue here? With specialty tiers, more health plans are transferring the increased cost of prescription drugs onto patients in the form of coinsurance. So you might be familiar with your copay for your office visit, and that's generally a flat fee. But now we're seeing plans using more coinsurance, which is a percentage of cost as opposed to a flat fee. So unfortunately what that means when that's the case is oftentimes the costs become higher for the patient. So that's something that we want to keep track of and overcome if we can. Patients living with rare, serious, or chronic conditions are disproportionately impacted by this shift in cost sharing because we're not seeing all drugs being moved into places where coinsurance is being used. We're seeing patients who are living with just that, rare, serious, and chronic conditions. We're seeing their medications being moved into coinsurance. So we really feel that it's discriminatory and, again, is unfortunately impacting patients who are the sickest. Some plans have moved factor from major medical coverage to prescription drug coverage, and that's really something that we want to highlight today. It may not affect you today with your plan or your form of coverage, but you never know what can happen tomorrow or next year. And one of the things that we watch is trends. And again, we're seeing plans in all 50 states on a certain level start to move factor from that major medical, which has been mostly the traditional way to cover it, into prescription, where it's covered very differently. So we want to make sure that you're aware of those changes that are coming down the pike so that when you choose those plans, you're looking at the right things, but then also to hopefully spur you to become involved on an advocacy level so that you don't have these access barriers in the future. Next slide. And again, just to give you some sample of what this looks like on the ground, when you get your insurance policy at the beginning of the year, you will hopefully be given information about the tiers that your prescription drugs will be falling into. If not, it's definitely something that you should request. If it's not easy to find, that's something that we also want to know because we want to make sure that plans are making that type of information very transparent and easily accessible for you. So in Tier 1, you'll generally see a generic drug, which is the lowest cost, and again, that flat rate copay. So that could be something like a $5 antibiotic. A Tier 2 is what we consider a preferred drug, and typically that's a medium cost. Again, that's a flat rate copay. So you could be looking at a drug that could be $50 for a 30-day supply. Then we move into Tier 3, which are non-preferred drugs. That's typically higher, but again, it's a flat rate. So you know ahead of time when you go to the pharmacy exactly how much that's going to cost you per month because of that flat rate. Then we start moving into Tier 4, Tier 5, and we've even started to see some Tier 6s, and those are what we consider specialty tiers. Overwhelmingly, the drugs that are being moved into those tiers are unique, high-cost, and again, the patient is charged a coinsurance as opposed to a flat rate. So they're charged that percentage of cost. We're seeing biologics, we're seeing forms of oral chemo, really just across the board. Again, patients who are chronically ill, who need obviously life-saving access to these drugs, we're seeing those consistently put into these higher cost tiers. Next slide. So to give you a little bit of an overview, obviously it would be wonderful if we could tackle everything at the national level, but we are working in tandem on both the national level and state, and we'll talk about state in just a second, to overcome these challenges in different ways because of how insurance is set up and how the governance of insurance is set up. We want to make sure, again, that we're moving on all fronts to try and tackle these access challenges. So on the national level, there's a very large group of patient advocacy organizations, including PSI and HFA, that are working on HR 460, or the Patients Access to Treatment Act. And that coalition is called the Coalition for Accessible Treatments. And we've been working on that bill for a couple years now. Again, it's a wonderful vehicle to highlight what our patients are facing and going through. And what that bill does is, if enacted, would basically say that a plan cannot charge more for a drug placed on a specialty tier than it can charge for drugs placed on their non-preferred brand tier. So it ties those two together, and generally what it does is hopefully level the playing field for patients so that if your drug is being moved or requires special handling, that it's not discriminatorily placed in a higher cost tier for you. And that will apply to plans covered under ERISA, and that's an important distinction that we'll make in just a second. But again, as you can see, state legislation is needed because ERISA doesn't cover everything. So again, those are sort of the different pronged approaches that we try and take to make sure that we can face those access challenges on all levels. Next slide. So what's happening in the states? That's really where a lot of the activity is happening. Despite the fact that we have 460 and we have a robust list of bipartisan co-sponsors, that really is an ongoing effort and a vehicle for us. But in the states, things are moving very quickly. So that, again, is why we want to make sure that you know what's happening so that you can get involved in your state with your chapter, with HFA, with NHF, when things are going on, because they're moving so quickly, and we need you guys to tell us your stories and to get down there to those state houses to let your legislators know as well. So what states have bills right now? Oh, sorry, can we go back? I think we just, nope, keep going. We just want to go to the state one. Right there, thank you. So what states have bills right now? So Alaska has a 90-day notice before there's a change to your tier structure. One of the biggest successes has been Delaware. That was really the first state to pass a $150 monthly cap on specialty tier medications, and that's something that is being replicated in lots of other states. So you'll also see Louisiana, you'll see Maryland, and those again have been our big successes. So a lot of the states, depending on where you're listening in from today, this year when you go to your advocacy day, you may be hearing about these bills, and that's wonderful. In Maine, what they took a little bit of a different tact, so there's a $3,500 yearly cap. So you can see that the states are tackling it differently. It could be how they're set up, what's going to work best in their state, or what specific challenges they're facing. So it's good to kind of, again, be familiar with these types of things. So when you're asked to weigh in and talk about what your organization would like to support, you can kind of see how they're fitting and how they'll affect you. What you should be looking for this year out of Pennsylvania, there was a study bill, so we're looking for legislation this year. In Virginia, We had a study bill as well a few years ago. Last year we had a success with a 30-day notification bill. So again, the patient will receive 30 days notice if their drug's being moved to a higher cost tier. We're coming out with a cap bill as well this year, $100 monthly cap, so we're hoping to have success with that. And then you'll also see a star next to Montana. That's been kind of a new development in the fight against specialty tiers. Recently, their insurance commissioner reached out to the marketplace plans, and they've been able to place limits on the usage of coinsurance and around specialty tier drugs. So that's another tact that you might want to take in your state and you might see happening, you might hear about, is reaching out to those insurance commissioners. Obviously, as a unique population, you want to have a good relationship and dialogue with them anyway. But regarding this issue, it's a great place to start, and Montana is a great sort of litmus test for you to talk about that. And again, if you need more resources or information about that, you can contact PSI or HFA, and we can kind of let you know more. Next slide. Again, in 2014, what are some things that you want to be looking for? And then what were introduced. California took, again, a bit of a different tact. They attempted to spread out the out-of-pocket costs over 12 months for those specialty tier drugs. So essentially, you take that cost for the year and just divide by 12 and be able to pay that per month. Connecticut had 100, Illinois had 100 for a 30-day supply, and there's, again, lots of different states after that success in Delaware, Maryland, and Louisiana that are really going after these cap bills to try and make those expenses for you affordable on a monthly basis. Next slide. So helpful resources. I point people to HFA's resource on specialty tiers every day because I think it's one of the best available. They have very easy to understand sort of informational one-pagers, talking points if you happen to be going to your state house or developing those for your state advocacy day coming up. Again, they're very well organized, they're easy to understand, and they're easy for you to use on the ground. So please, please take advantage of them. And if there's anything else that's not on there or that you think would be beneficial, obviously let HFA know as well, because these things move so rapidly, and we want to be on top of what's happening in 2015 to make sure that we're there to give you the support that you need. So, and also through PSI, if we can help, please let us know. So that was a really brief overview, but again, just wanted to give you sort of a flavor for how exciting and fast these bills are moving, because it may not affect you today, but it might affect you tomorrow. So we want you to be well informed and hopefully participate. So again, thank you so much for the chance to speak with you today. And Katie has my contact information, and I'm happy to take questions at the end. Thank you.
Thank you so much, Kelly. We're going to move on to, like as I said, going over a little bit of some prior authorization and things you may see, and then some biosimilars legislation that you may see. And I realized I didn't introduce myself, Katie Verb, Manager of Advocacy and Government Relations. Sure. Hopefully I've spoken with those that are on before, and I will be going over that from here on out. So prior authorization, what is the issue? When you see a prior authorization bill, what they are generally are standardization bills. So the process for prior authorization of prescription drugs and services can be very cumbersome and time-consuming, and a lot of the bills that are coming up in states seek to streamline that process, or they will charge the state insurance commissioner or the state Department of Health with streamlining the process based on a set of criteria. So it's important to note that if you see a prior authorization bill, it might not apply right away. It might be a bill that charges your state departments with streamlining the process. So it's important to look at when those processes will be put in place. Put up a brief list of some examples of some standardization criteria that we're seeing. Forms must be uniform. There's a lot of different forms out there for different companies, a lot of doctors and providers to go through filling out multiple forms. It can be very frustrating. So making the forms uniform, making the system available electronically. A lot of them don't force the system to be electronic, but they force that at least be available electronically. The other two good things that we're seeing that are really good for patients is they set a time period for response. So what they say is that if a provider submits a prior authorization request and they haven't heard back from the payer within a certain time period, typically it's 72 hours, sometimes it's 2 business days, then that means that the request is automatically granted. So that puts a little bit of the onus on those forms to be approved and to be looked at, and makes the process a little bit speedier. And then the second thing that we're also seeing is that there's a set time period. Some companies have that if they approve something, you have to do it every month, and I'm sure, as you know, that can be very time consuming. So this will say typically it's 3 months, but some say 6 months. If you've approved a product if you've approved a product, it will be approved for 6 months. Next slide. So these are states that have already enacted bills. I have a little asterisk there because these are states where we have, where HSA has member origin. So, and it's by no means an exhaustive list. And if I've missed something, please feel free to email me or let me know. But this is some of the states that have passed bills and some examples of what they are. As you can see, Arkansas, they have the creation of the uniform form that must be no longer than 2 pages, submitted electronically, and then the 72-hour grant. Iowa, just this past year, passed a bill that charged the insurance commissioner with developing faster prior authorization rules and followed a lot of the things that we saw on the last slide. Minnesota, the commissioner must publish criteria and standards used to determine if providers must obtain prior authorization for services. And in Mississippi, again, the standardized form, no longer than 2 pages, electronic submissions, etc. New Mexico, their bill applied solely to Medicaid contractors. So for all companies that contract with Medicaid, they have to have a uniform form, must be submitted electronically. They said no longer than 2 business days. If they don't respond, automatically approved, and then the form no longer than 2 pages. And then North Dakota said that it must be available electronically. So those are some examples of some of the states that have done bills. So next up, you might be seeing some issues surrounding biosimilar legislation, and we just wanted to give you a brief rundown of what that is. And you know, if you start, this topic has been coming up more and more lately. So just as a side note, on a national effort, if you hear about biosimilars, it will be concerning the FDA. The FDA is putting out some rules right now concerning interchangeability. But right now in the states, what you'll be seeing are physician-patient notification bills. So many states are passing legislation that requires that patients and or physicians must be notified if a pharmacist substitutes their biologics with a biosimilar. So these bills right now are a little bit premature in the states, given that there has not been a biosimilar approved in the United States. So under the things to consider, we have, there are no biosimilars approved, and in the approval process for these things take years. I believe 1, maybe two requests for approval were just filed in the past maybe 3 months for biosimilar products, none of them related to bleeding disorders, to the FDA, and that process will take a long time. But again, there has not been an application for a bleeding disorder biosimilar product. Another thing is that some of these bills that have been enacted, they sunset, which means that over time, after certain portions cease to be effective after a certain number of years. So what's interesting is that some of these bills were passed, and they will sunset before there are products on the market. So just some examples of elements that you might see in some of these bills for you. A lot of them require that a record of any substitutions are kept for a certain amount of time, 1, 2, 3 years. Then you're either going to see the patient must be notified of the switch, the physician must be notified of the switch, or both. And then the other thing you're seeing is that the State Board of Pharmacy must keep a list of approved biosimilars. A lot of the states have worked that into their bills. Next slide, please. So here are some states that have enacted bills. Again, another asterisk. We really focus on where our members are, and if Again, if there's something I have missed, please feel free to let us know. Delaware has a notify patient and prescriber in writing, unless the prescriber has indicated that he wishes to not have a switch, and then the pharmacist must keep records of the switch for up to 3 years. Now, Florida has and Virginia have done the same thing. They're waiting for the FDA rules to come out, and if the FDA rules label a biosimilar as interchangeable, and what that means is that according to a certain set of criteria, that biosimilar and that biologic are inherently the same. But right now, not only is the FDA is determining what that criteria will be. So we're still in the very beginning stages of determining what the criteria for interchangeable and interchangeability will be, as opposed to even determining whether or not a product is interchangeable. So some of these states have said, okay, so if, once the FDA makes up their mind about that and we get those rules, then a set of certain things will happen. Indiana has a notified patient and prescriber, especially if the prescriber states that they allow for a substitution and then requires the Board of Pharmacy to keep a list. Massachusetts also has you may substitute and then notify the patient. We genuinely support a patient and physician notification bill. We believe that patients and physicians have the right to be notified when their medicines are switched, especially in a population such as ours that's very well educated and very high touch. Oregon, it says, has a may substitute unless, or they may not substitute unless they notify the patient or prescriber. Again, a Board of Pharmacy list, but the prescriber notification requirement here in Oregon, again, expires in 2016. So that's interesting. It will have expired most likely before any biosimilars make it to market. And then again, in Virginia, there's the prescriber notification expires in 2015, but the patient portions of those bills do not expire. So that's an interesting note there. So after those are two areas where we're seeing a lot of legislation in the states. But I also wanted to briefly cover. Kelly had mentioned what happened in Montana, and I'll go over some kind of alternative advocacy solutions and alternative things that you can be doing next year to advance some of the causes of the bleeding disorders community in your state. So in Montana, I know Kelly had mentioned the insurance commissioner used, instead of using legislation, what they did was they used a combination of their regulatory authority to authorize plans and a specific Montana discrimination law that talks about unfair trade practices to limit the use of coinsurance. So to avoid discrimination in plans, the commissioner has the ability to authorize plans and authorize their structure. And what they said is that your plans are discriminatory because two or three portions of your plans, Tier 1, Tier 2, Tier 3, offer a copay, and Tier 4 offers a coinsurance. So that portion of the plan violates this unfair trade practices law in Montana. Therefore, we will not approve them. It's, again, using their regulatory authority to put that into place and to make sure that each tier uses a uniform structure in how they charge. Now, one thing to note there is that every single plan, according to this solution, every single plan in Montana could choose to use coinsurance to regulate each of those tiers. And each tier would be regulated the same way. It would no longer be considered discriminatory practice. The chances are very unlikely that that will happen, but this was a loophole. It was a caveat that the insurance commissioner found in order to address this problem. There are other ways to do that. There are other laws that are in place in each state. There might be a law such as the Montana law, or there might be a law that came into place when that state ratified certain portions of the ACA. But what you can do as an advocate in your state is to set up a meeting with your insurance commissioner, set up a meeting with their office, with their staff, specifically their general counsel, and discuss with them how the issue of specialty tiers is affecting you and how all insurance issues are affecting you. You know, this is just one example of a way that they have used some regulatory authority to accomplish something that a lot of people are doing legislatively. They couldn't. It seemed that in Montana they couldn't get the legislative fix at the time, and so this is how they went about doing it. But there are a lot of different issues that you can talk to your state insurance commissioner about. This is just one of them, but developing that relationship as an advocate can be really important. Talking to them about special tiers, talking to them about network adequacy, talking to them about all of those things, and having that relationship and educating them about bleeding disorders can be really helpful. It can be a very helpful relationship. Another relationship I wanted to point out, next slide please. I was recently at a meeting in New Jersey and at the PAC meeting, and this relationship was brought to my attention, and I thought it was really interesting and very, it's something that, it's a relationship that they have nurtured in New Jersey, and it seems to have worked out very well. And I wanted to talk a little bit about the Title V programs and just a very, very brief overview, and then let you know how some of those relationships can be good for advocacy in states. So your state's Title V program is Title V of the Social Security Act, which established the Maternal Child Health Program. Seeks to improve the health of all mothers and children. It's been around since 1935 with various amendments in the 80s and early 90s. But and again, this is it's a complex funding program, and this is a very basic overview. But I wanted to point this out because I wanted to show that, you know, hemophilia diagnostic and treatment centers have a special category in it. So under Title V, a percentage of this money that's allocated for these maternal child health programs, and it's a relationship between federal and state programs, where this money was allocated on a federal level through the Social Security Act and is used in different state health departments, and establishes either, you know, a maternal child health department or they'll call it a Title V department, or however the different state chooses to identify it. But under that, there's money for these special projects of regional and national significance, or SPRANs. And one SPRANs category are hemophilia diagnostic and treatment centers. So you'll find these programs, and you'll find that this is located within your state departments of health, and that they are there. Hemophilia is a portion of this, so states are aware. And if you just do the next slide, please. One thing that you can do is meet with the director and their staff and make them more aware. You know, learn about the program to begin with, and then meet with the director and staff and start educating. You can attend meetings that they attend, educate them about hemophilia, loop them into chapter activities, ask to be on the mailing list for that department. They have advisory committees, ask to sit on existing advisory committees, and try to loop yourself into there, because it can be a very advantageous relationship to have someone within the State Department of Health that deals with these grants, that deals with health programs, to really know who you are and know what your chapter does, and et cetera. Next slide, please. So what's next? If there's a bill or issue that you would like help with from us, please let us know. We've got a lot of toolkits, a lot of issue briefs. We can help follow up with some alternative advocacy solutions. That was a brief overview, like I said. We just wanted to bring those things to your attention. If you'd like to learn more, if you think that's something that you would like to participate in, or your chapter would like to participate in or learn more about, we can certainly talk to you about the inner workings of those things, and help you get in touch with those people. We do have those resources. That's my email address right there. And then next slide. That is that is it. Thank you very much for attending. Special thanks to Kelly, and I would like to open it up for questions if